No problem, no problem. Say, I want
Yeah.
main things to be there.
Yeah. Yes.
Can you see my screen, guys?
Yep.
Yeah, we are getting it. We are getting it.
Okay.
We are getting it.
Uh, Thank you all for inviting me to give this talk. It's a fantastic journey that I have been on so far, coming from Stanley, where we all spent many years in our undergraduate careers, to my uh, place of abode, should I say, in St. James's Hospital in Dublin, which is the biggest teaching hospital in Ireland. And it is the biggest vascular unit in the island of Ireland. So it's a particular privilege to be part of this unit and to contribute to the advancement of vascular surgery as a whole. So I know this is a picture from our own batch. Uh, Many of us have a lot more hair. We look a lot younger. And unfortunately, there are many in this photograph who are no longer with us. So we remember them, and we remember the good times we had with many of them. So certainly for Stanley, yeah, I have lots of fond memories. We have lifelong friendships. We have a sense of camaraderie and belonging, and we'll never forget, or I'll never forget, the lunch on the veranda outside biochemistry, and the many times that we all sat and had a cigarette outside, and of course the many escapades in the exam hall, many of which will go, which will go unmentioned. And as I said before, I will remember lots of friends in that picture who are no longer with us. So, uh, going throughout medical school, my house urgency, and my training in Stanley, I'll be honest and say that I never knew what an aneurysm was. My knowledge of aneurysms was confined to Asghar Ali's notes, which I have a scanned version in my Dropbox. And most of what I knew was related to this uh, book, and also from Bailey and Love. Right throughout, I'm not sure how many of us have seen an aneurysm during our undergraduate and training years in Stanley. So it certainly wasn't something that I was well versed with. You remember some of these pictures from Envy's unit, and Dr. Vardarajan, I don't know if you all know or remember that we used to stay in his house in ABM Avenue. And when I visited Madras last year, went and visited him, and he enjoys drinking a whiskey. And I sat down and we had a few whiskeys with him in his house. He has become quite old and frail and is a little bit, forgetful, but he's still able to cope and lives in the same house that I lived in for about 15 years. So, 2016, I'd gone back with my children and wife Kaveri, and as you can see in this picture here, that is us. And Rosie kindly met us that day, and I went to our anatomy department, which is still, the tables are very much the same. It's a little bit different, and I took my kids to our lecture room and showed them where I would sit and all the scribbles and marks we made on the tables behind. And obviously, in the front hall, still proud to say my name is up there in that board showing that I was a University Blue. So my interest in vascular surgery started in 1987 when I was in Whitehaven in England. I went on to a training post in Norwich, and then made a career decision to train in vascular surgery, returned to the Lake District, and then came back to Ireland. Aortic surgery in the 90s was certainly an open only operation. It was a big operation. There was considerable risk. And as we all know, the results were very variable, as many of these procedures were done by non specialist vascular surgeons. And the concept of vascular surgery being done by specialist vascular surgeons was only emerging at that stage. So I was in that cusp of that changeover. So I saw what was coming. And this is an aneurysm that I dealt with some years ago by means of open surgery. Large 7 centimeter aneurysm that is repaired with a standard open bifurcated graft. And that is the big midline incision that was used. And even at that stage, we were constantly looking at ways of minimizing the insult to patients. And there was a surgeon in the US who pioneered so-called mini laparotomy surgery, which was that. And as you can see, these marks above and below, that one there, and these are little stab incisions through which you could put clamps to clamp the infrarenal aorta and the iliac arteries, which allowed us to carry out the procedure through really, which is an 8 centimeter incision. The use of these kind of self-retaining instruments made it a lot easier for us to operate and took away the tedium that some of our trainees had to undergo to retract for the operating surgeon. The only problem with this is that this kind of surgery with this kind of an access to the vessel is not really well disposed to training our trainees. And in our unit, maybe 90% of our workload is done by our trainees. So if you had to train people to do aortic surgery with an 8 centimeter incision, as you can see here, can be a bit challenging. So it's not something that is very easy to do. Clearly, morbidity associated with open surgery is not insignificant. There is the issue of long incisions, pulmonary complications, ileus, the hemodynamic consequences of cross clamping, and the cost of hospital stay and recovery. And the mortality is not small. In the best of units, I would say the mortality of open surgery is between 1 and 10% in those days. And this is significant morbidity, but the 5-year survival was not bad. And problems. What we do know is that if you have an MI after open surgery, you have a 60% mortality. If you have renal failure, it's 50% mortality. And unfortunately, if you end up with bowel ischemia, the mortality is enormous of about 70%. The other smaller issues of leg ischemia and coagulopathies are stuff that can be coped with, but nevertheless do pose a problem for our patients. Disruptive technologies are there all the time, and this is the endovascular theater that came with my job when I was appointed in James's. It's about $1.5 million investment, and my senior colleagues saw the way in which vascular surgery was going maybe 15, 20 years before I was appointed. And they were the pioneers of so-called endovascular surgery in Ireland. And that is the strength of our unit because we have been ahead of the curve in many a situation. And this kind of facility allows us to do things very, very differently. What is very important to note is that this facility is owned, run, and managed by the vascular surgeons. And, although it is based in the radiology area, it is run by us as vascular surgeons. So this is a very, very important thing to keep in mind when we talk later on. So this is a patient that I treated some years ago. As you can see, this is a patient treated with a stent graft, and I did this patient percutaneously with 1 centimeter incisions in the groin. We use closure devices to close the access sites, and as you can see, this is really minimally invasive to the nth degree. So rapidly, endovascular aneurysm surgery became the new gold standard, and it was pushed by lots of people in many different ways. So this is a patient that I treated maybe about 10 years ago, and it tells you how things can change and have changed. He presented to the ED at about 2 o'clock with collapse. He was rushed to the CT scanner, where a ruptured aneurysm was diagnosed at 2:30. I was called. We had a quick look at the CT scan. It was found to be anatomically suitable for endovascular repair, and he was transferred to the endovascular suite at 3 o'clock. So this is the kind of imaging that we have. This is a 3D reconstruction taken from a DICOM data set on our CT scanner. We have our own workstation, and in fact, this is a workstation I have on my laptop, which I'm speaking to you on. As you can see, there is this large aneurysm with a huge retroperitoneal hematoma on the right-hand side. And earlier on, you could see a bit of contrast in that area denoting a rupture. So He was moved into the operating room. This is actually a composite set of images from that patient. You have a stent graft in place with a pigtail catheter, which allows you to show the renal arteries. You start deploying the graft, which is deployed in a stepwise manner to deploy the device. You cannulate the contralateral gate. You measure the length of device that you need, and you complete the repair with an extension on this side and another one on this side. As you can see, that's the iliac bifurcation, and that is a completion run showing the renal arteries that are patent. The aneurysm has been sealed. You can see the outline of the aorta there, and good flow into both internal iliac arteries. So this is the timeline of this patient, right? ED at 1427, CT scan at 1450, theater at 1520, completion of procedure at 1450. He was moved to recovery about 30 minutes later, moved to HDU at 8:30, and he was on oral fluids by 10 o'clock at night. Okay, so this is something that could not and would not happen if he were treated with open surgery. And this is the same man at 10 o'clock at night having a sip from with his cup. And what I will tell you is that this man was done under local anesthetic, with bilateral groin cut down. So there was no question of him being put asleep, and certainly in patients who are treated such, there is an advantage in doing them under local. So he was in HDU for a few days, and he was discharged home on day 13, and he has been well since. And what is very nice is for us to get a 74th birthday party picture. That is him a few weeks after he went home, to show that he was alive and well. And it's always good to get a card from the patient's relatives saying how good it was to have him back home. So it does make it worthwhile when we push the boundaries to treat patients such as this. So you have to ask yourself, why do we do endovascular repairs? Well, it's an exciting alternative to open surgery. It certainly allows us to treat a lot of high-risk patients, which in the past we would not have been able to. It is minimally invasive, less trauma. The recovery is night and day compared to open surgery. And uh, like many things, this is an enormous growth industry. So medical device manufacturers are constantly responding with different modifications and design approaches to allow enhanced and better stent grafts to be manufactured. And of course, let's be honest, guys, it is a cool operation. And most of us in surgery and medicine like to be involved in good and newer techniques which are of benefit to the patient. It certainly is less operative time, less, if any, ICU stay, and most of these patients who are done endovascularly go home in 24 to 48 hours. But there is the downside. You do have to have an increase in preoperative imaging. There's the issue about postoperative surveillance. And the big bugbear of this kind of technique is the increase in secondary interventions. And of course, the cost of the device, which in our institution, we have a procedure price, which is about €7,500. But if you take into account all the sheets, catheters, wires, and everything, it's close to about €10,000 per patient per instance. So it's not cheap, okay? But it certainly allows us to treat difficult patients like this morbidly obese man with a horseshoe kidney with a large aneurysm, which in the past we would have balked at treating because the technical challenges associated with having a horseshoe kidney are not insignificant and would have led to a lot of issues with morbidity and mortality. So this is a patient that I treated with a stent graft, and as far as I'm aware, is still knocking around without any problems. So what's happening here? One sec. So there is the issue of, I suppose, other things like, for example, you have this patient, right, who I treated with an endovascular repair. As you can see, there's a stent graft in place, and you can see a fairly sizable, what's called a type 1A endoleak at the top end, which is this blush outside the, the stent graft. And I used a balloon expandable stent called a Palmas stent to straighten the neck, and unfortunately ended up occluding the renal artery. So we had to very quickly convert to an open procedure where I ran a bypass from the aorta down to the left renal artery. So, that's the kind of stuff that sometimes catches you out. The issue about reinterventions are looked upon by many to be the problem with endovascular repair, but it's important to understand that most of these are catheter based. The majority of these are successful, and it's likened to an angioplasty that we carry out for peripheral vascular disease and for coronary artery disease. So, although it is there, it is not something that we in vascular surgery look upon as a major problem. The key is in surveillance and making sure you treat them at the right time, in the right place, with the right techniques. So, we do know that if you convert to an open repair for whatever reason, the mortality is high. If you don't convert at all, the mortality with stented patients is about 2 to 2.5%. If you convert on the table at the time of primary procedure, it's about 20%, and the late mortality is about 11 to 12% because of the fact that when you have a stent graft in place, it's difficult to put a clamp on suprarenally. If you have a rupture with a stent graft in, and that does happen in less than about 1% of patients, the mortality rate is about 60%. The key, of course, is the fact that any of these devices are mechanical. You do have metal fatigue. As you can see here, the arrow points to a barb, which is on the top end of the stent that has come off from the stent graft. And this is why you need to be following these patients on a regular basis. Make sure that the stent geometry is, correct. And as you can see, this stent has separated off from the top end of the stent graft. Thankfully, these kind of occurrences are few and far between with newer devices, but nevertheless, it still does happen. You can see this is another one in a Cook Zenith graft where the top stent has completely separated from the fabric covered ceiling stent lower down. And you can get patients whose stent grafts have holes in this. And this is again fabric wear and tear and erosion. And in some devices, you get almost a hygroma that forms inside the sac. This was particularly related to certain devices like the Gore device, which had expanded PTFE as part of the fabric. And it is related to the porosity of the fabric, which has been now fixed by a modification which includes another layer on the stent graft. So you don't see this any longer. And sometimes if you have a patient whose sac continues to grow, and when you open the sac, you literally see this watering can kind of stent graft where you get multitude pinholes where the sutures were used to hold the fabric onto the stent graft. So newer fabrics and suture materials have meant this kind of occurrence is not very common indeed. Unfortunately, ruptures do happen, as this is a patient of mine that ended up in another institution, and they did not know this patient had a stented aneurysm in situ. And when they opened, they found the stent graft winking at them. So it was a bit of a shock to them, but the patient did do all right after being salvaged this way. Now, the standard endovascular repair is not there and cannot be used for every patient because of various different anatomical challenges. As you can see in this patient, these are the two renal arteries, and there is no neck over here to treat this patient with a standard stent graft. So, you do need to have different devices. This is called a fenestrated stent graft, where you have openings, and you can see the 4 radiopaque markers for the right renal and the 4 radiopaque markers for the left renal. And you cannulate these, and then you bridge them with stents. And you're basically, what you've done is you've moved the sealing zone from here to the suprarenal and the celiac and the visceral aorta. So this is the kind of techniques that are there. And as you can see, this is a Zenith custom stent graft with a completed repair in situ. So this does allow you to expand the role of expand the role of stent graft applications in patients who otherwise would be a prohibitively high risk for open surgery. And even if you have, say, for example, a common iliac aneurysm, you do have iliac branch devices that you use to allow you to cannulate and put in bridging stents to separate, to seal off these aneurysms. And now you can treat everything from the top end with a fenestrated component to the iliac component, which have a branch stent graft. So uh, these are all techniques and devices that are available, but this fenestrated stent graft, for example, costs about 16,000 euro. And again, when you take into account all the bridging stents and wires and catheters per patient, you're talking about a cost of about 22,000 euro. So where are we at the moment? Well, it's low perioperative mortality. There definitely is better survival out to 5 years. Um, does it uh, cause a less number of people to get neck enlargement post open repair? Jury is still out. And there is a fairly low risk of post-operative rupture in these patients. There are lots of contentious issues with this kind of technology, as I'm quite sure you'll understand. Do we offer this for all patients with a rupture? In our institution, that certainly is the case because we have a trained team. All of us in the unit are well versed with treating these patients. If at all a patient can be stented in a ruptured situation, that is what we would do because the survival of patients is much, much higher. You talk about different stent devices, whether you have suprarenal fixation or infrarenal fixation. I won't go into that because that is again a matter that we could talk about for a few hours. And the key, as I've said before, is the surveillance. Is it CT or duplex? In my unit, we would do a duplex scan every 6 months and a CT scan at year one, and then maybe every 2 years to get a very detailed look of it. If you look at a patient such as this who's morbidly obese, you can think of how difficult it is going to be to do him open. But we managed to treat him endovascularly. And the techniques that we have allow you to treat literally everything from the aortic valve all the way down to the iliac bifurcation. So lots of options are there. But like with every one of these situations, you have to choose the right device. You have to choose the right procedure for the right patient at the right time. So uh, I would perhaps spend more time turning patients down than operating on them because it is all about patient selection that allows you to get good results. When you have patients who are not suitable for these stent grafted techniques, you can do hybrid repairs like this patient. You take a reversed graft from the iliac artery to debranch the visceral vessels, and you can stent all the way down from the subclavian all the way down. So this again allows you to treat a certain proportion of patients who otherwise would not be deemed suitable to be treated due to various anesthetic and other comorbidities. Whether or not it is right in treating these patients is another matter, but this patient has been done. As far as I'm aware, she's still alive 8 years down the road, so it's doing quite well. So it is really new. It is really a new horizon for many of us involved in these kind of patients. And to get good results, I think you have to have appropriate case selection. You have to plan these cases very, very, very carefully. And for any of us who are involved in this kind of treatment, you need to have an availability of a range of devices and have a plan A, plan B, and a plan C. And you have to be trained to deal with all the problems that you might encounter. Now, this is not a very proud moment of mine, I can tell you. Originally, this is the kind of anatomical configuration that we had. And at the time we decided to treat this patient with a stent graft, and in hindsight, you look upon these kind of patients and say, what the hell were you doing? As you can see, there's little, if any, neck. It's diseased at best. you have a good result. But down the road, you can see this whole stent graft has slipped down from there down to there. And I actually ended up explanting this device. And the patient thankfully has done well. So for any of us to get good results, you need to have a good neck. You need to have healthy sealing zones. You need to have an adequate lumen at the bifurcation. And as you can see in this patient, it's only a 12 millimeter bifurcation, which certainly is not suitable for a stent graft. And as I tell my trainees, there is no substitute for seal. If you can't seal uh, a device in these patients, you should not be doing an endovascular procedure. So, uh, how do I plan my cases? Now, planning is the key for all of these patients, right? This is a screenshot taken from my own laptop, which I have, as I said, a 3D workstation on my machine. This is done literally in real time, and the recording is real time, where you use the DICOM data set from the CT scanner to do a 3D reconstruction. You can do a center line measurement. You can check the angles that are required. You look for the neck, you look at the bifurcation, you look at the iliacs, you look at the tortuosity. And as part and parcel of all of this, you plan on the positioning of the C arm for this procedure, because like everything in life, you have to plan, and you have to plan for what problems they may occur, and for you to be able to make decisions based on how you have assessed these patients. So it is hugely important to get all of this right, because if you don't, that's when you run into problems. Don't forget, we are dealing with radiation. So for me, it is a particular emphasis for me and my trainees to minimize the screening time. We use lead shields for the operator assistant, lead glasses, and you do lots of things to minimize the radiation dose that you might be exposed to, given that you're going to be dealing with so many of these patients in your lifetime. So you cannot take radiation lightly. So I would always use bony landmarks to plan. As you can see, this is a patient with a stent graft in place. I do not do a run till the devices is in place. And you can actually end up doing a complete procedure with 25 cc of contrast, because we use less than, we use half strength contrast for our runs. And with modern interventional and X-ray equipment, the images you get are fantastic. So you can do away with a lot of these things. Now, this is a thoracic patient that I treated in April 2010 with a long disease segment right up to the celiac artery. As you can see, we use 4 stents in this case. And in follow-up, as you can see, the whole stent morphology has changed. And what we had missed was, if you look at this picture on the top right, there's a bit of thrombus lining the inside of the graft. And that is always a telltale sign there's something wrong. And if you look very carefully, there is disconnection of the stents between at the lower end. So we had to actually re-intervene on this patient. It was phenomenally difficult because the stented aorta becomes very stiff and rigid. And when you're pushing a big device up the iliac artery, as you can see here, I ruptured it. And we salvaged this with a covered stent, which we always have on the set. So as I said, lifelong follow-up is mandatory for all of these patients. With 3D workstations as well, you can remove all the contrast. You can look at the metal on all these stents. And as you can see in this patient, there is a disconnect between the contralateral limb and the device. So uh, how is it applied? Well, it would say 25 to 90% in the literature. In James's, when I started, it was about 10 to 15%. In 2011, it was about 80%. And as you learn from bad experience, I suppose, you realize that it's probably going to be about 60 to 70%. And this is data from our own unit from 1978 onwards. I started in the year 2000, as you can see over here. And the number of cases of stented patients in purple went up, and we did many, many more stented operations than open operations. And as you learn from your experience, the number of cases we have started coming down in the patients that we are treating. and being more selective in who we offer these treatments to. So I'll end by saying that there is no substitute for experience, and one has to learn from our mistakes, and one has to learn from our bad choices of procedure, maybe stents, and also timing of surgery. So it's hugely important that we learn from this and pass it on to our trainees. And I don't know if Roy's around, but that's where I'm going to be in a few hours' time. That is our golf club down the road. And I hope in a few hours' time, that'll be me with a pint of Guinness looking out over the 18th. Thank you very much, guys.
Thank you, Prakash. Can you just unshare your screen so bring in all the guys on the gallery view?
Hold on one sec.
Okay.
Prakash,
Yes.
your experience with dissection aorta or internal arteries, iliac arteries.
Sorry, just one sec, JP. Let me just, I just want to unshare my screen. What's happening here?
Hey, Purki.
Hey.
Hey, good talk, man.
Thank you. Thank you. One sec, I just try to figure out how.
I think you put the radiologist in a place to sleep.
It's done now.
Yeah. Look, I mean, you brought up a very important thing, Roy. I mean, certainly in our unit, right, my two senior colleagues who are now well retired, they saw the way in which vascular surgery was going many, many years ahead of what in other places. So they went down the road of training themselves in doing endovascular surgery, endovascular intervention. So in our unit, apart from the selective embolizations of inferior mesenteric arteries and lumbar vessels, every bit of vascular surgery is done by us. Every bit.
Okay.
So it is not a model that, for example, works in the UK, because in the UK it's very different. And the term that I use is turkeys will not be voting for Christmas. And with radiology and IR, it certainly is a massive issue for them, because they see that vascular surgeons are taking over a lot of what they were doing traditionally. And I can understand that, but at the same time, for us, there is no way in which I will hand over 80% of my practice to somebody else. I'm sorry, it's not going to happen.
So JP,
Good
can you ask your question again, and then Selva Lakshmi?
Hello.
JP, are you there?
Hello.
Yeah. Go on.
The dissection aorta
Yes.
Yeah.
experience, Prakash Madhavan.
Okay. With the type A dissections are solely within the remit of the cardiothoracic surgeons. Okay, so we don't get involved in them. Sometimes they would operate on the type A, and for follow-up, we might be asked to deal with the residual dissection distally. For the type B dissections, there are only the only reasons why we would get involved in intervening is for symptomatic patients with branch vessel ischemia. That could be either bowel ischemia, renal ischemia, leg ischemia. And in those kind of patients, the cardiac surgeons will be happy to throw those patients to us, because to treat them with open surgery is an enormous task. And I certainly would, our unit certainly would be very keen and willing to stent a lot of these patients. And it's astonishing to see how well these patients do with a single stent graft to seal the entry tear, which usually is just beyond the left subclavian artery.
Thanks, Selva Lakshmi, and then Surabhi.
Yeah, Prakash, have you dealt with any aortic tumors?
Aortic tumors, no, Selva Lakshmi. We don't see. Sorry, no, that's not entirely correct. I've helped treat a couple of patients with neuroendocrine tumors, but we don't see many of that. No.
What is your experience on a carotid aneurysm?
Okay, carotid aneurysms usually are related to post-surgery ones. In other words, they have been operated on before and you have a patch repair. You can get a patch infection. and you get a carotid aneurysm. That is the most common in our practice. You do get a small number of patients who have carotid aneurysms de novo, and I've again operated on maybe 3 or 4 of them in my lifetime. It's very, very rare. Usually, the way in which I repair those is with a vein graft using autologous long saphenous vein.
Long saphenous. Okay, thank you.
Surabhi.
Hi, Prakash.
Hi, Surabhi.
Yeah, you're doing an excellent job. I have a close relative who underwent aortic abdominal aortic aneurysm 15 years back in Narayana Irdhyala. You must be heard of it.
Yes.
It's in Bangalore. Yeah, the Dr. Devi Shetty and their team. They took a long time to decide the team, and finally they have done it. Because why I'm asking this question now? Where is it? This endovascular surgery is available in South India, because I was roaming, I was literally running around the hospital and hospital. In Chennai, they refused to take up the surgery. Even in Coimbatore, they refused to take up the surgery. But finally, we landed up in Narayana Irdhyalaya. Finally, the surgery has been done, but it's an only open. I don't think in, those days they were not doing the endovascular surgery. But the patient is doing very well now. And I'd like to know where this endovascular surgery is taken up in South India.
Okay, Sylvia, I think that's a good question to ask. And I'll be honest with you and say that the number of people who deal with this endovascally is quite small overall, for the simple reason, I think the main issue is, as far as I'm aware, is cost. All right. And if you're not doing this on a regular basis, I'm sorry, you can't get good results. All right. This is not a case that you can do one operation once a year and expect to be a master at it. You can't do that. So, for the last 15 years, I have sponsored a trainee or a surgeon from India to come and spend 6 weeks, 3 months in our unit. And in fact, in MMC, in the vascular unit, there is we donated the old C-arm from my institution to MMC, and it is there. And I'd gone there a few years ago, and we did the first case over there of an angioplasty. But there a lot of the people who have come and spent time in our unit are well used to doing all of this, but I'm not sure, Surabhi, where in South India it is done. Maybe Roy will be able to tell you.
Yeah.
Yeah.
Can I come in?
Yep.
Yes,
Roy.
please, sir.
Yep.
Yeah. The best place in Chennai, I think it is Vijaya and Ramachandra. In both these places, they do endovascular stuff. And both these guys are very close friends of mine. They were trained in Chitrathirunal.
Oh,
And in Vijaya, they do it along with Dr. Bashi. He also does it in SIMS.
Okay.
They do quite a lot of aortic work and endovascular work, carotid work in Vijaya and in Ramachandra.
Okay.
I think, Prakash, from what Surabhi is saying, I think she's giving you an invitation to come back to Chennai, I think.
Yes. Everyone will be very happy to receive you, Prakash.
Roy, your business will go down, man.
I don't do anything endovascular. I don't like seeing blood.
No, our classmate
Thank you,
Perumal could have been saved.
Okay,
Our classmate Perumal could have been saved if Prakash is here.
Okay,
Yeah,
Prakash, I wanted to ask a couple of questions. One is, you said that sometimes when the stents or they migrate,
Yes.
and then you have to take them back. So what kind of, is it an urgent situation? What kind of symptoms do the patient have? Is it just ischemia or do they bleed?
See, Suresh, when you follow these patients up, when you have stent migration, a lot of them are completely asymptomatic, and you pick them up because you're following them up with either duplex or CT scan. When you identify the stents are migrated, you do need to decide on how you're going to re-intervene. You could do it, I suppose, you could decide to do nothing and continue watching. You could re-intervene by adding in cuffs or limb extensions, or final option is to take the whole graft out. all right?
Mhm.
And that is a small, but again, steady number of cases that we do in our unit. We certainly have the biggest experience with so-called explants, and we get them from all around the country because people don't want to take these on because they are fairly, complex. They can be quite high risk. And as I said, you can't be doing just one of these cases every 3 or 4 years. So we would certainly tend to get most of other people's disasters to deal with in our institution. So it's only a small number of patients who perhaps will not attend for follow-up, who have got stent migrations, who have got endo leaks that end up with ruptures. So it's a very small proportion of patients. About 1% of patients will end up with ruptures.
Yeah. I mean, I can tell you how much of a transformation or whatever, the revolution this has caused, because we all remember it during the initial years when we came here, we used to see lots of ruptured aortic aneurysms coming to district general hospitals here. And those patients will be on the table sometimes for 6, 7, 8 hours, 16, 20 units of blood. They'll be in ITU and then die after a month. And this is a big revolution, doing these kind of things endovascularly. And I think that's made a big difference to survivors, I'm sure.
Yeah, you're absolutely right, Suresh. And I think the thing as well is that, good judgment comes from bad experience, all right? And the initial enthusiasm to completely go from open to fully endo, I think is wrong, okay?
Yeah.
We have certainly, the pendulum has swung one way and is coming back the other way. So we are a lot more circumspect about offering people endo procedures. We would be a lot more keen on turning people down. In our unit, we turn down perhaps 30% of our aortas, all right, 30%, because we feel it is not worth treating them because of comorbidities or complexities, not because we can't put in a stent. We can probably put in a stent and get away with it, but is it right for the patient? If there's somebody in a wheelchair on home oxygen, what the hell are you going to be treating a 5.5 centimeter aneurysm for?
Yeah.
Those are the kind of things that we have become a little bit better at looking at and deciding and treating, or as I say, not treating these patients.
Okay. And just finally, did you say that you have also treated some superior mesenteric artery aneurysms?
Yes.
Oh yeah, because I think one of my colleagues here, he's also an anesthetist. He had a superior mesenteric artery aneurysm, and he nearly died after surgery. He went to Middlesbrough. They've never done this before, the vascular surgeon there, and they undertook this procedure, and he nearly died, and luckily he survived. But now he is being looked after by a specialist vascular surgeon in Newcastle. So that gave me an insight into how tricky a superior mesenteric artery aneurysm could be. Yeah. Lovely. Anybody else has got any questions? Surabhi and Roy, your hands are still up. Must be the hands of legacy. So
I don't know how to put my hands down there.
Same
I've been
thing.
trying to do that.
Same thing here, Roy.
So, Nati.
Yeah.
Do you want to give a final kind of thing?
Yes. I think it's
Yes.
Post-COVID sequelae in vascular, post-COVID sequelae patient. I have seen one complete occlusion of brachial artery. I have seen. He was thrombolized immediately.
Yeah. No, JP, I think there's a lot of talk about the so-called procoagulant effects of COVID. And certainly thrombosis is a big issue in intensive care patients. I have not, touch wood, so far treated anybody in our institution with COVID with a vascular problem, all right? Currently, I think we have only 3 patients in ICU, and we do have 3 wards closed because of COVID contacts. But for whatever reason, we don't see a lot of patients who have had vascular problems after COVID. Originally, you're right, there were lots of reports of prothrombotic problems with strokes, leg ischemia, aortic occlusions. all of that, but I have not seen any of those.
Coming.
Prakash, I have actually recorded this presentation. You don't mind uploading it on YouTube or anything like that, do you?
Oh, not at all.
Okay. Yeah, that's fine.
Prakash,
Prakash,
உனக்கு பிரேக்ஃபாஸ்டா உனக்கு வெயில் அடிக்கிற மாதிரி
Prakash.
தெரியுது.
ஆமா இப்பதான் இதாயிருக்கு. Yes, Surabhi, yeah.
வெயில் அடிக்குது.
Srimati.
No, it's not me.
Yes. Prakash.
Yes.
Oh, sorry, Srimati. Yes, sorry.
Prakash, hi. No questions. Nice to see you in a challenging specialty like endovascular surgery.
Thank you very much.
Yeah, it was really nice.
Srimati, we normally see your face. Today you've decided to
Yeah.
have only audio, is it?
Yeah, if you see my face now, you'll be scared. That's why.
எங்க ஊர்ல மழை பெஞ்ச ஊரெல்லாம் தண்ணி.
வீட்லயும் தண்ணீர் சொல்லு.
நட்டி பாரு எப்படி தெரிகிறாருன்னு.
இல்ல அது தண்ணியில ஊறி மலையேறது.
உள்ளேயும் தண்ணி வெளியிலேயும் தண்ணீராய்.
ஆமா, அப்படியே மலையேறது.
தண்ணியிலேயே மிதந்துட்டு இருக்காங்க எல்லாரும்.
ரெக்கார்டிங்க கட் பண்ணிட்டேன்ப்பா.
ஓகே,
என்ன வேணா பேசலாம்.
I think we can call it a day, I think.
Okay.
Any more questions? Thank you, Prakash Madhavan, for giving us a very nice
Great talk, Prakash.
Thank you, guys. Thanks very much.
Thank you.
Nice to see you all again after a long time. And hopefully we'll meet again in Madras soon.
It's not only a good presentation, it's a very high end of the thing that where you are doing, which is it's not just the talk, it's what you are achieving. That also is very evident.
Very proud of you, Madhavan.
Yes. All proud of you, Madhavan, being as our classmate.
Thanks,
once
Solda.
again.
Thanks,
Where did you go to?
Aja, I will be missing that Guinness that you are going to have.
Yeah.
No, but two years ago.
Some time for that is after golf.
No, it's funny, but 2 years ago, see, in 2016, when I came, the day after I met Rosie in Stanley, one of the trainees who came from Stanley to Dublin was there in Stanley, and he said, come do some cases with me. So went to the theater and did a couple of endo cases with him. And they were, I think from what I gathered, they were building their new unit and they were hoping to get a completely new ward and new IR equipment installed. I'm not sure if that has happened as yet. So it'll be interesting to go back once all of that is ready, because it's good to see how people have, coping with very different situations in India.
Okay, thank you all. If you all agree, I will end this call.
Thank you, guys.
Prakash, have a nice day at the golf course.
Bye. Keep well, keep safe.
Yes,
Thank
all of you.
Thank you.
Keep
Thank
the
you. Thank you.
the mantra now.